Okay. I do want to announce my disclosures. I'm a consultant to Zimmer and Oculus. And then when we talk about corneal ectasia, there's many forms, but the two that I want to focus on today are keratoconus and maybe not just flagrant keratoconus, but preclinical keratoconus, and why the biomechanics are important in evaluating response to intervention, as well as post-laser vision correction keratoconus. Ron Kruger has talked about identifying the at-risk cornea pre-op, but also early detection post-op to allow intervention. So I would like to put forth a hypothesis, which is actually in the literature, that curvature, thickness, and elevation changes are actually secondary symptoms of developing ectasia, whether keratoconus or post-laser vision correction, and that the primary corneal alteration is focal biomechanical alterations, focal, not global. So if you have this focal reduction in modulus of elasticity or focal weakening, that immediately redistributes the stress. And the first thing that's going to happen is that area deforms a little more, it's going to thin. Thinning also redistributes the stress. And then as a response to that, the curvature is going to increase. And increasing the curvature actually decreases the stress. I'll show you what I mean in a few minutes, but that also redistributes the stress. So this cycle, this biomechanical cycle, leads to progression in keratoconus, decompensation in post-laser vision correction. The asymmetry of properties in keratoconus has been demonstrated clinically, not clinically, but in a research lab, but in vivo in keratoconic subjects by Giuliano Scarcelli in Brion microscopy, and it shows the difference between a normal map and then a keratoconic map. So basically, you can think of keratoconus and post-LASIK ectasia as well as a focal weakening. And in a suspect cornea pre-op, the likely initial change is focal biomechanical weakening, which has to occur prior to the changes in thickness and elevation. And certainly, you know, Ron was looking into the future for biomechanical detection. And I think biomechanical detection, not based on specific magnitude, but on asymmetry of properties, would be an excellent way to approach detection. So if you think about it, you've got this anterior surface of the cornea, and you have this one area that becomes weak. The whole cornea is loaded by the IOP, and then this one area is going to deform more because it has less resistance. So it thins, and then there's a greater curvature. So let's think about the curvature and the influence of the curvature. So if we look at Laplace's law and you look at this balloon, you look at the area of greatest curvature here, and there's really very, very little tension. Whereas the rest of the balloon with less curvature has greater tension, and curvature, radius of curvature, is in the numerator here. So what that means is greater curvature is smaller radius of curvature, lower wall tension. So let's think of that in terms of the cornea and hoop stress. And with hoop stress, the stress is the pressure times the radius of curvature divided by twice the thickness. So what really drives this stress distribution? Is it thinner? Yes, because the smaller t in the denominator will cause this number to be higher, but also flatter. So if you have flatter curvature, then there's greater radius of curvature in the numerator, and the stress will go up. So in keratoconus, what dominates this stress distribution? Is it thickness or is it curvature? Do areas of thinner pachymetry have greater curvature and peak stress, as is often assumed? Well, if you look at this particular curvature map, which is the typical appearance of keratoconus, so that this area of pathology is also the steepest area, and you see the calculation of the von Mises stresses that goes with that, it does not correspond to the pachymetry pattern. It corresponds to the curvature pattern, because the lowest stress is in the area of greatest curvature. And what I propose here is, this is why John Kanellopoulos' approach to treating keratoconus by removing tissue out here. If you remove tissue out here, you can reduce the stress, which will allow, so as that area comes up, the area of the cone will go down. So curvature drives the maximum stress distribution, and not thickness, as is often assumed. So you can remove tissue in the flattest areas of keratoconus. Now, what about after laser vision correction? So we'll focus on the unstable biomechanical decompensation leading to the development of ectasia, which can have two causes. One is the at-risk cornea pre-op, and the other is too much tissue remove. And I want to say this is a profile. This is not a one-dimensional depth in the center, but it's the profile of tissue removal which determines the stress distribution. And if you think about it, preoperatively, the steepest area is in the center. That's also the thinnest. So you have the lower stress, high curvature with the higher stress thickness. And yet after refractive surgery, you take that central area with the lowest thickness and make it the flattest. So how does post laser vision correction ectasia evolve? Well, the anterior surface has epithelium that smooths out what happens there and mass evolving changes. So this is going to be first detectable on the posterior surface where there's no epithelium to smooth it out. Therefore, it is very important to understand normal changes to the posterior surface relative to pre-op before recognizing abnormal changes related to developing ectasia. So if we look at, and these patients were all treated back in the 90s when the ablation profiles were quite spherical, which is less biomechanically friendly. So I want to show you the result of 2,380 myopic patients with pre-op and 6-month post-op orb scan topography. So I want you to look at this upper left image, which is an elevation difference map average for all 2,380 patients. And what we did here, there's no reference surfaces. We took the pre-op reference surface and we took the pre-op elevation and the post-op elevation and fit them to each other. So the two references, the two surfaces are fit without any references. Now, if we divide that up by level of correction, again, keep your eye on this upper left map, and we go to the 25 with less than 2 diopters, and then 2 to 4, 4 to 6, 6 to 8. I want you to notice as this area in the center is coming up, you are also getting an area out here which is going down, 8 to 10, greater than 10. So you have this area of elevation in the center surrounded by area of lower elevation in the mid periphery. So what causes that? Is it central decompensation? And certainly you're going to have an area of greater curvature and elevation in the center, but you don't have this, this lower elevation area in the periphery to match what I showed you. Is it a forward vault? And again, it's not compensated here by something that's happening in the periphery. So if you think of this posterior surface, where in this image, this top is the pre-op, the bottom is the post-op. So you have inward swelling, and this is due to the water redistribution, due to the change in tension in the lamellae by tissue removal. So this actually moves inward as the water shifts into the periphery where there's peripheral lamellar segments that can't keep the water out. And you have this inward movement. So you get relative increase in curvature in the center of the posterior surface and relative increase in elevation in a normal post-op. So again, if you do these different fit patterns and you see the only one is this backward peripheral movement due to the water redistribution is the one that fits our 2,380 cases. So the posterior surface, this change relative to pre-op is stable remodeling and not ectasia. So is this consistent with other devices than orb scan? And it is. It's been shown in Penicam that there's an increase in central posterior elevation compared to pre-op that decreased with time. In the Galilei, increase in central posterior curvature compared to pre-op that decreased with time. So what this tells you is you need to have at least 2 post-op, not one post-op that you compare to pre-op, but 2 post-ops to look for changes. So early posterior surface changes, increase in central elevation and curvature relative to pre-op are normal. Posterior changes should decrease with time. So if they increase in 2 successive post-operative measurements, then you can be suspicious of post-laser vision correction ectasia. And there's an article that's being published in terms of looking to the future, is currently an EPUB ahead of print, which is a new index for detecting unstable post-laser vision correction corneas versus stable ones. So my final thought here is if you look at keratoconus versus post-laser vision correction, even if the anterior surface is similar between them, underneath that, the structure is extremely different. And the response to treatment, such as risk cross-linking in either of these cases, is going to be in response to the underlying structure. And so you would expect differences. So I would like to encourage everyone not to group keratoconus and post-laser vision ectasia treatment in the same group when you're analyzing outcomes, because I think your post-laser vision correction may skew your results. Thank you very much.
Thank you. That was wonderful. A reminder to the participants, you can put a question in the chat, or you alternatively can raise your hand. Let's see. We did have one question, because we do have a little bit of time here, from Dr. Lobanov. Would it not make more sense to use a femtosecond corneal relaxing incision, cutting down 90% of depth of corneal fibers to reduce the tension adjacent to the cone, rather than excimer ablation of topography of the cone?
Well, you're talking about a single cut there, so a single cut as opposed to that's deep. So you make all those lamellae without tension. That's a very complicated biomechanical shape. Whereas if you take down some tissue opposite the cone over an area, you're not cutting the lamellae. So I think it would be, I would propose in keratoconus, if you do 90-degree cuts, I think that's would encourage further decompensation. You don't want to cut those lamellae all the way down and turn your keratoconus into a post-laser vision correction on top of the keratoconus. You want to maintain some intact lamellae in those corneas. So I would advocate for tissue removal in the flat area that surrounds the cone, and don't touch the cone. And that will, I can just tell you right now, that will decrease the curvature of the cone. If you ablate away from the cone without touching it, you will decrease the curvature of the cone because you redistribute the stress in a region not deep.